Right, we come to the last class today. So we'll sum up the entire ECG course in a single class. So this is, so as you have seen last so many classes, you have seen the bits and pieces, right? Now we are going to combine all the bits and pieces and come to a reasonably complete ECG reading. So before you read an ECG, you must make sure the patient's name, what is the sex, age, and also the standardization and the speed, and make sure the ECG belongs to that particular patient. Many times the ECG you see may not belong to that particular patient, so you may be treating some other disease for some other patient. So all these things happen. So first we start with the P wave. So the P wave is the first wave you see in your ECG. So first thing is the P wave is due to what? Biatrial depolarization. Good, it's due to biatrial. It's not atrial depolarization. You must always say biatrial depolarization. So the P waves, what you must see is three things. Whether it is tall, whether it is wide, or tall and wide. Tall is right atrial enlargement, wide is left atrial enlargement, tall and wide is biatrial enlargement. So just see this 2.5. Remember 2.5 for P wave. And in addition to that, I want you to see whether the P wave is inverted in L1. So I told you in sinus rhythm, the P wave is upright in L1. So the first line we start for sinus rhythm is P wave upright in L1. So the P wave is inverted in L1. You can see that P wave, if the P wave is L1, inverted in L1. So it means two things. One is the dextrocardia. Dextrocardia means your patient has got a right atrium is on the left side. So naturally, your AVL will be AVR and the AVR will be AVL. So actually, the P wave, the AVR, the L1 is equal to AVL. So the P wave will be inverted in L1 because from L1 the atrial depolarization will be going like this. So it will be inverted in L1. So whenever there is an inverted P wave in L1, always think of a dextrocardia. Once you think of a dextrocardia, look at the left-sided leads. You see this left-sided leads? Absolutely, there is no progression of R wave. You can see V1 to V5, V6. Everything is negative only. Normally what happens as you go along the left-sided leads, your R wave is likely to increase. Here you can see absolutely there is no R wave. Whereas you put the ECG leads on the right side and take an ECG, the R wave is nicely progressing on the right side. That means your left ventricle is on the right side. So whenever the P wave is inverted in L1, look at the left-sided leads. If the left-sided leads do not show a R wave progression, the same ECG you keep it on the same space, you keep it on the right side and take an ECG. If the R wave is progressing on the right side, you are dealing with the mirror image dextrocardia. That means your right atrium and the right ventricle is on the left side, left atrium and the left ventricle is on the right side. So this is a true dextrocardia. So whenever the P wave is inverted in L1, so we must always start with looking at the P wave is in L1. So L1 P wave upright, then see the contour of the P wave, height and the width of the P wave. So you can see that P wave is upright in L1, sorry, inverted in L1 and upright in AVR. Normally it is the other way. P wave is upright in L1 and inverted in AVR. Sometimes our technician will produce dextrocardia. Our technician will produce dextrocardia by interchanging the leads because our technicians are so busy people. Sometimes they tie down the right limb lead to the left limb and left limb to the right limb. So they will produce what is known as a technical dextrocardia. In those situations also, you will have a P wave inverted in L1 because the technician is now tying down the left upper limb to the right upper limb and the right upper limb to the it is not, the patient's right atrium is not on the left side. Because this fellow has reversed the leads, once again you will have a P wave inverted in L1 and the P wave upright in AVR. But if you look at the chest leads which is taken on the left side, you see the normal progression of left-sided leads. That means his left ventricle is on the left side only. So whenever you have a normal progression on the left side with the P wave inverted in L1, it is technician-induced dextrocardia. Whereas whenever the P wave is inverted in L1 and there is non-progression of R wave V1 to V6, then you are dealing with the true dextrocardia. So always, so as far as the P wave is concerned, look at the P wave in L1, look at the width, look at the height, right? That is for P wave. So then you see whether the P wave is present or absent. If the P wave is absent, RR interval is irregular, what is your diagnosis? Atrial fibrillation. So whenever the P wave is absent, the only diagnosis we must maintain is atrial fibrillation. So when the P wave is not followed by a QRS, if the P wave is not followed by a QRS, what is your diagnosis? If the P wave is not pass, what pass? What pass? If the P wave is there not followed by QRS, what pass? AV block, AV conduction disturbance, that means AV block. So we see whether the P waves are followed by QRS. If the P wave is not followed by QRS, it is an AV block. It can be a second degree block or it can be a third degree block. Whereas the P wave has got no relation to the QRS and the P wave is occurring on the T wave in various portions of your QRS complex, what's your diagnosis? Atrioventricular dissociation. So these are the P waves you must see, whether P wave is upright in L1, tall, wide, present or absent, whether it is followed by a QRS, whether you have a fixed relationship between the P and the QRS. If there is no fixed relationship between P and the QRS, it is AV dissociation. Most common causes are complete oblong. So these are the things you must see in P wave. So many things, but very easy things, isn't it? So that's about the P wave. Then we look at the PR interval. PR interval represent what? Now you have become little more informed about ECG. You should not call them as AV nodal delay. You must tell us AV conduction. PR interval represent atrioventricular. It's not only the delay. Most of the PR interval is contributed by the AV nodal delay, but it is not purely AV nodal delay. The PR interval tells you what is the time taken for from the sinus node to reach the ventricle. Is the PR interval represents the time delay from the sinus node has produced an impulse, it has come out of the atrium. From that atrial depolarization, AV nodal delay, then the conduction through the bundle of His, then the conduction through the bundles, Purkinje, then the ventricular depolarization. So what does your PR interval represent? Atrioventricular conduction. It is mainly contributed by this interval is mainly contributed by the AV nodal delay. But the PR interval represents atrioventricular conduction. There are only two things for PR interval. Short, wide. Where is it short? Accessory pathway. When the AV node is bypassed. Accessory pathway, WPW syndrome. Where the PR interval is long? First degree atrioventricular block. All the P waves are conducted but with delay. So the PR interval can be short, PR interval can be long. The PR interval is variable in which situation? PR interval is keep on varying in which situation? Second degree atrioventricular block. Type 1, second degree atrioventricular block, you have a variable PR interval. So PR interval can be short, PR interval can be long, PR interval can be variable. So these are the three situations as far as the PR interval is concerned. Then what is the next wave which is coming? Q. So difference between a pathological Q versus the physiological Q. So whenever the Q wave is there, in which leads you have the physiological Q? In which leads you will have physiological Q? Lead V5, V6 which represent septal activation. So V5, V6 represents septal activation occurring from left to right. So this results in small pathological Q. Then you have to see whether the Q wave is pathological or physiological. The definition of a pathological Q is it is more than 2 millimeters deep, it is more than 25% of the succeeding R wave, and it is wide, more than 0.04 second in duration. So deep and broad Q waves. The Q wave is broad, Q wave is deep, and it is more than 25% of the succeeding R wave. You call them as pathological Q wave. All the other Q waves are physiological. Especially in V5, V6, they represent the septal activation from left to right. When the pathological Q wave was there, your diagnosis is exactly chronic total occlusion. I don't want you to say infarction. It is chronic total occlusion of the particular artery. So that is a Q wave. Then we come to the QRS complex. QRS complex represent biventricular depolarization. So QRS complex represent biventricular depolarization. So once again, whether QRS complex is big, QRS complex is small. When which condition QRS complex has got a large amplitude? ventricular enlargement. So if the QRS complex is of large amplitude in left-sided leads, satisfying the criteria of V1, V5, V6 more than 26 millimeters, S plus V1 more than 35 millimeters, it is a left ventricular. Once you decide it is a left ventricular enlargement, then the next question is whether it is a pressure overload, volume overload. Then look at the secondary STT change. Amplitude is abnormal, you have a secondary STT change, it is a pressure overload. Amplitude is abnormal, if you have a normal STT change, it is a volume overload. Whereas your P wave in your QRS complex in V1 is abnormal, you have a tall R wave in V1. Your RS ratio in V1 is more than 1, or absolute height of the R wave in more than 7 millimeters in V1, especially when it is associated with right axis deviation and the right atrial enlargement, the diagnosis is right ventricular hypertrophy. So whenever the QRS is big, either it is a left ventricular hypertrophy or left ventricular enlargement or a right ventricular enlargement. Once again, in this pressure overload or the volume overload, then according to the conditions. Then one thing I did not tell you is whenever the QRS complex is small, when it's got a low amplitude, what is the diagnosis? So whenever the QRS complex is too small, you must suspect a pericardial effusion or the obese patient or a patient with a mixed edema. So the definition of a low voltage QRS complex, what is the definition of a low voltage QRS complex? If your limb lead QRS complex is less than 5 millimeters and your chest lead QRS complexes are less than 10 millimeters in voltage, this is definition of a low voltage QRS. Three important conditions: pericardial effusion, a gross obesity and myxedema are the conditions in which you will get low voltage QRS complex. It can happen only in 1% of normal people, low voltage. So you must see the QRS is tall or small. So that is about the amplitude of the QRS. Then what is the abnormality, second abnormality of the QRS? Widening of the QRS. Very good. So before we go to the widening, we know the QRS axis. So before we go the widening, we must know the QRS axis, electrical axis. Remember this diagram? Have you seen this diagram somewhere? Yes, somewhere in your life you have seen in dreams. So L1 is what lead? L2 is intermediate lead, AVF is vertical lead, L3 is right sided lead, AVL is left sided lead, AVR is no man's land. So if you remember this, the calculation of the axis is very easy. So as far as the calculation of axis is concerned, you will first look at where your positive QRS is. The tallest positive QRS, if it is in L1, L2 or in AVF, you are dealing with the normal axis. Once you decide it's a normal axis, always look at the AVR to confirm it's a normal axis, because all the waves, all the complex, all the components of the QRS complex and the P wave will be negative in AVR. Having decided it is normal axis, see which of these three leads have the tallest positive QRS complex. If the L1 has got the tallest positive QRS complex, the axis is 0, the position is horizontal. Whereas the L2 has got the tallest positive QRS complex, it is an intermediate heart, the axis is 60. Whereas AVF shows the tallest positive QRS complex, it is a vertical heart, the axis is plus 90. So if none of these three leads show the tallest positive QRS complex, look at the lead 3 and lead AVL. If the lead 3 shows the tallest positive QRS complex, it is a right axis deviation, and always look at the AVL to confirm it is a right axis, because AVL will be showing the deepest negativity and L3 will showing the tallest positivity. The commonest cause of right axis deviation is right ventricular hypertrophy. If the AVL shows the tallest positive QRS complex, the axis is minus 30, it is a left axis deviation. Always look at the L3 to confirm. AVL will have the tallest positivity, L3 will have the deepest negativity. The commonest cause of left axis deviation is left anterofascicular block. So always look also for left ventricular hypertrophy. If none of these 5 leads show the tallest positive QRS complex, then look at the lead AVR. The AVR shows the tallest positive QRS complex. Most often it is an indeterminate axis, because all these 5 leads will show either equiphasic complex or negative QRS complexes. Right? It's only 5 minutes. Axis is only less than 5 minutes subject. So it's made so complex. So you are so thorough with the axis. So looking at the ECG, you know what is the axis is. Right? Any doubts in axis? No. So the QRS is next is the axis. We have finished the axis. So this is the axis deviation. If it is a left axis deviation, left atrial vesicular block. If it is a right axis deviation, right ventricular hypertrophy due to various reasons. Please remember the number. L1 is 0, L2 is plus 60, AVF is plus 90, L3 is plus 120, AVR is minus 150, AVL is minus 30. So just remember the number. As soon as you can see the ECG, you can see the number. Then the next abnormality of the QRS is, it is wide. What is the normal duration of QRS? 0.08 second. So whenever the QRS is wide, there are two important differential diagnoses. Whether QRS is wide because of the initial delay or the QRS is wide because of terminal delay. So whenever the QRS is wide because of the initial delay, it is WPW syndrome or anomalous Kent pathway with a short PR interval. Usually it is associated with a short PR interval. So whenever the QRS is wide because of the terminal delay, it is bundle branch block. So that is the commonest diagnosis is bundle branch block. So whether the QRS complex is wide or the QRS complex may be vary in shape. So it may be varying in size. Certain QRS complex are big, certain QRS complex are alternatively big and short QRS complexes. It's called electrical alternance. So that can happen in pericardial effusion. So pericardial effusion can produce alternate big and short QRS complexes. So QRS complex can be tall, QRS complex can be small, QRS complex can be variable in size, and sometimes QRS complex can be absent. In which situation it is absent? Complete heart block or cardiac standstill. So cardiac standstill or ventricular fibrillation. What is our treatment of choice here? CCR, not pacing, not defibrillation. For any cardiac arrest, the first important treatment of choice is rapid, at least 100 to 200 per minute. The effective, correct cardiac massage. It is not a cardiac massage to the skin. It is effective cardiac massage to the heart. So the first treatment of choice is cardiocerebral resuscitation. So the QRS complex can be absent in cardiac asystole or the ventricular fibrillation. So that is about the QRS. Is it? QRS is okay. Then what is the most important segment now? ST segment is what segment? Widow making segment. So the QRS widening summary: initial delay WPW, terminal delay bundle branch block. If it is terminal delayed slurred positivity, then you decide whether the terminal delayed positivity is over the right sided leads, it is a right bundle branch block. If it is a left sided leads, it is a left bundle branch block. Right bundle branch block can happen in 5% of normal individual. If the QRS is less than 0.12, it is an incomplete bundle branch block. If it is more than 0.02, it is a complete bundle branch block. And of course, always look for secondary STT changes. Whenever the QRS depolarization is delayed, you expect the T wave to go in the opposite direction. So normally, the depolarization travel from endocardium to epicardium, repolarization travel from epicardium to endocardium. In bundle branch blocks and in ventricular hypertrophy, where the depolarization is delayed, repolarization starts from endocardium to epicardium, resulting in the T wave change opposite to the QRS complex. So that is about the summary of our bundle branch blocks. Then the most important segment is ST segment. ST segment is the gap between the end of depolarization to the beginning of repolarization. So only two things can happen in ST segment. One is elevated, another is depressed. When it is elevated, what is the diagnosis? When it is ST is elevated, what is the diagnosis? Acute total occlusion, which is in a subepicardial injury. Whereas the ST segment is depressed, what is the diagnosis? Acute critical occlusion. What is the difference in treatment of choice? So you just look at the leads here. So always remember the leads. V1 to V4 left antidescending artery, V5, V6 L1 AVL circumflex artery, L2, L3 AVF right coronary artery. So always look at the leads to see which artery is diseased. So once the artery is diseased, there are three manifestations of coronary disease: ischemia, injury and infarction. So see which of this is there. Ischemia is usually chronic moderate occlusion. Infarction is a chronic total occlusion. Injury is always an acute occlusion. If it is ST elevation, it is acute total occlusion, the treatment of choice is, first treatment of choice in ECG room is soluble aspirin and clopidogrel. Soluble aspirin of 325 milligram and clopidogrel at ECG room itself as soon as you see this ECG. Then thrombolyze within how many minutes of entry to the hospital? Within 15 minutes. A good hospital, an excellent hospital should thrombolyze within 15 minutes of entry into the hospital. Door to needle time less than 30 minutes. So whenever you have a chest pain with an ST elevation, this is the treatment of choice. It is acute total occlusion. So then you have the evolution of ST elevation myocardial infarction. The phases of ST elevation infarction are hyperacute phase, fully evolved phase, fully evolved subacute phase, and chronic stabilized phase. So in hyperacute phase, the important thing is the whole thing is injury. The whole thing is epicardial injury. The earliest sign is the loss of concavity, which is called slope elevation of ST segment, and subsequently ST elevation with concavity upwards and a upright T wave and a reciprocal depression. So this is the stage we have no myocardial infarction. Here at this point there is no death of myocardial cells. So opening the artery at this point in time will prevent a complete necrosis of the myocardium. So urgent is your aspirin, clopidogrel, thrombolysis as soon as possible, or a direct PCI. Whereas after 1 or 2 days, 2 or 3 days after the infarction, the patient goes for a fully evolved phase of infarction, where you have all the 3 signs of the ECG: injury, ischemia, and infarction. You have a central area of infarction producing the Q wave, surrounding area of still persistent injury producing the ST segment, the peripheral area of ischemia which has recovered from the injury and producing the T wave inversion. At this point, high dose statins, aspirin, clopidogrel, beta blockers, and AC inhibitor, and trying to control all the risk factors, the patient is in the hospital. Whereas subacute fully evolved phase at this point in time, because of the treatment, patient's ST settles down. So the patient is left alone with the central area of necrosis, which is a Q wave, surrounding area of ischemia, which is a symmetrical T wave inversion. At this point, you discharge the patient with what are the 5 drugs the patient should be on? Aspirin, clopidogrel, high dose statins, beta blocker, and AC inhibitor. So don't discharge without these 5 drugs if there are no contraindications. So at this point in time, you will stratify the patient to be maintained on medical line of management or invasive line. Of course, in chronic stabilized phase for months and years after the infarction, the ischemia is also getting treated. The patient is left with the telltale sign of a permanent necrosis of the Q wave with a normal ST and a normal T wave. So here your job is to prevent the other myocardial or the next myocardial infarction. So this is an evolution of an ST segment elevation myocardial infarction and the treatment of choice according to the time you see and according to the time from the occlusion you see, you plan the appropriate management. Whereas when the patient comes to you with acute chest pain with this ECG change, your treatment of choice will be with, what does it represent? Acute critical occlusion. So this ECG represents acute critical occlusion. What drug you will not give? You will not thrombolyze this patient. You will not thrombolyze this patient who is coming to the acute chest pain with the ST segment depression. So that is a subendocardial injury indicating a sign of an acute unstable angina or a non-ST elevation MI due to acute critical thrombus. This thrombus is rich in what? Platelet. Whereas the thrombus which produces ST elevation is rich in fibrin. That's why you give a fibrinolytic therapy. Right. Then comes the T wave. The T wave, what is a normal T wave? 40 and 20. It should not be more than 40% of the preceding hour, or it should be at least 20% of preceding hour. If the T wave is tall, 2 differential diagnoses, ischemia and hyperkalemia. You got to look at the contour of the T wave. Sharp apex, narrow base, it is hyperkalemia. Blunt apex, broad base, it is ischemia. Whereas when the T wave is of low amplitude, it could be a hypokalemia or a non-specific STT change. So this is as far as the upright T wave is concerned. When the T wave is inverted, once again 2 different diagnoses. Secondary STT change or a primary STT change. Then once again you look at the contour of the T wave and the ST segment. If the T wave is asymmetrical, downsloping ST segment, and the T wave is completely asymmetrical, associated with an abnormality of the depolarization like a tall QRS or a wide QRS, your STT wave is secondary. Whereas the QRS is normal, not wide, not tall, and has got a well-formed ST segment with a symmetrical upslope and downslope of the T wave, symmetrical T wave inversion, it is the ischemia. So it's the primary T wave change which is ischemia. So the T wave can be tall, T wave can be small, T wave can be inverted. So what are the important differential diagnosis and how you arrive at a particular diagnosis. So that's about the T wave, tall, small, inverted. That's all about the T wave, right? Then we come to the most difficult part is arrhythmia. What is an arrhythmia? Any rhythm other than normal sinus rhythm. 6 criteria for normal sinus rhythm. Upright P in L1, inverted in AVR, constant PP cycle, constant PR interval, constant RR cycle, heart rate between 60 to 100. Any rhythm which does not satisfy even one of this criteria is an arrhythmia. Arrhythmia is divided into bradyarrhythmia, tachyarrhythmia according to the rate. Anything less than 60 is brady, anything above 100 is tachy. Once again, both are divided into irregular and regular arrhythmias. Regular brady, regular tachy, or irregular brady or irregular tachycardia. The commonest example of an increased irritability of the heart is a premature beat. The premature beat or those beats come before the next expected sinus beat. The premature beats can arise from a supraventricular focus like atrium or junction, or it can arise from the ventricle. So you identify this whether it is a supraventricular or ventricular by looking at the width of the QRS. If your ventricular premature beat has got a narrow QRS, it is a supraventricular premature beat. Then it could be junction or it could be atrium. So you carefully look an abnormal P wave in front of the QRS. If the patient has got a premature beat preceded by an abnormal P wave, it is atrial premature beat. If the narrow QRS is not preceded by an abnormal P wave, it is junctional premature beat. If the QRS complex is wide, it is ventricular premature beat. Ventricular premature beat is likely to have dash compensatory pause, complete compensatory pause, and supraventricular ectopic is likely to have incomplete compensatory pause. So this is about the ventricular premature beats. Once you decide about ventricular premature beats, the most important thing is to identify whether the premature beat is benign or malignant. So for that, you have to look at the width of the QRS, the amplitude of the QRS, the notch of the QRS, the frequency of the QRS, whether it is relationship to the previous QRS of R and T, whether it is couplet, whether it is run, whether it is during an ST segment, during a tachycardia, and so on. So this is your summary of how to identify a malignant ventricular extrasystole. As far as the ventricular extrasystole is concerned, not all ventricular extrasystole need treatment. I told you, you need more courage for not treating an arrhythmia. You need only less courage to treat an arrhythmia. But when the VPD is there, you must be having a courage to say, I will not treat this. Because many of your antiarrhythmic drugs are more dangerous than arrhythmia themselves. So benign ventricular premature beats are left alone with the reassurance, most often not telling the patient that they have this. So many times after telling that, the people develop a problem rather than due to premature beats. So these are the indicators of the malignant premature beat, especially when you have an acute coronary syndrome. The most important thing is when the patient has got an acute coronary syndrome, you must carefully watch for all these signs. And the malignant premature beat are the runners, pre-runners of a dangerous ventricular tachycardia or a ventricular fibrillation. Suppressing them at this stage itself will prevent a future ventricular fibrillation or a dangerous ventricular tachycardia. So the tachyarrhythmia approach will be, tachycardias are nothing but succession of premature beat. More than 3 without intervening sinus beat is a tachycardia, isn't it? Succession of premature beats. More than 3 is a run. More than 3 succession of premature beats without intervening pace is a tachycardia. The heart rate is more than 100 per minute. Once you decide it is a tachycardia, the heart rate is more than 100, then you have to decide whether it is a narrow QRS complex tachycardia or a wide QRS complex tachycardia, depending upon the QRS duration. If the QRS duration is less than 0.08 second, it is a narrow QRS complex tachycardia. Then apply the same rule, regular or irregular. Once it is regular, if it is a narrow QRS, it is a supraventricular tachycardia. That means your focus of origin is above the bundle of his and it is traveling through the normal pathway like the sinus beat. That's why the QRS is narrow. Once again, just like you decide for the premature beat, then you decide whether this narrow QRS tachycardia is an atrial tachycardia or a junctional tachycardia, depending upon whether the P wave is coming in front of the tachycardic QRS complex. If there is no P wave, it is a junctional tachycardia. If there is a P wave, it is atrial tachycardia. When this atrial tachycardia rate is so fast, more than 300 per minute, the successive P wave will come immediately without intervening the baseline, which will give the ECG appearance of a sawtooth appearance or a picket fence appearance. So this is atrial flutter. So when there is a regular atrial tachycardia, it can be atrial tachycardia or atrial flutter. If there are no P waves, it is a junctional tachycardia. So if you have no P wave, P waves are replaced by a fibrillary wave, and the fibrillary wave and the RR interval is totally irregular, then the diagnosis is atrial fibrillation. Whenever there is a white QRS complex tachycardia, it is regular. When you make out the separate QRS and T wave, it can be when it's a regular QRS complex tachycardia, it could be a ventricular tachycardia or supraventricular tachycardia with aberrancy. So whenever you have this is atrial fibrillation. So remember how to calculate the rate in atrial fibrillation. You have to mark 6-second period and count number of QRS in that 6-second period and multiply into 10. So that is the average heart rate. Remember, 60 to 100 control rate, less than 60 slow ventricular response, 100 to 140 fast, more than 140 rapid. Right? So this is your calculation. So whenever there is a white QRS complex tachycardia is there, you must always go into the history first. First important thing is whether the patient is hemodynamically stable or unstable. So if it is unstable, direct electrical treatment. If it is a bradycardia, pacer. If it is a tachycardia, cardioversion or DC shock. When the patient is hemodynamically unstable. Only when the phenomenon is stable, you try to see what arrhythmia it is by looking at certain parameters. Whenever the patient with a white QRS complex tachycardia has got previous old myocardial infarction, LV dysfunction or heart failure, is a known case of cardiomyopathy. He is taking some drugs which can prolong QT interval, and he is in some electrolyte imbalance. Your white QRS complex tachycardia is ventricular tachycardia. So always look at the clinical pointers. So if the patient has got a monophasic pattern, a very white QRS with a monophasic pattern, single R wave, it is most often ventricular tachycardia. Whereas when the patient has got a triphasic pattern, R, S, R dash like that, just like our bundle branch block, it is most often supraventricular tachycardia with aberrancy. So that is about the tachycardia. So if it is a irregular white QRS complex tachycardia, it is either a atrial fibrillation with pre-existing bundle branch block or the polymorphic ventricular tachycardia. The QRS changes in shape, duration, axis and the RR interval. Everything changes. It's called tarsine, predominantly due to prolonged QT interval. If we make out only the QRS without a T wave, it is ventricular flutter. If you don't make out the QRS and T wave, it is ventricular fibrillation. The treatment of choice is cardiocerebral resuscitation, first followed by immediately as soon as possible with shock. So this is an approach to entire tachyarrhythmia, white QRS tachycardia and narrow QRS complex tachycardia, that differential diagnosis and so on. So these are the pointers, clinical pointers to decide whether the white QRS complex tachycardia is ventricular tachycardia or SVT with aberrancy. Then the bradyarrhythmia. The bradyarrhythmia, the heart rate is less than 60 per minute. So bradyarrhythmia can be classified into disorder of impulse formation or a disorder of impulse conduction. The classical example of impulse formation is a sinus bradycardia and a sinoatrial arrest. The classical example of impulse conduction is atrioventricular block. So the commonest physiological arrhythmia in children is sinus arrhythmia, where the heart rate quickens in inspiration and slows down in expiration. The one clinical condition which abolishes sinus arrhythmia in children is large atrial septal defect. So right coronary artery disease can produce sinus arrhythmia in adult. When it produces adult sinus arrhythmia, it is most often not related to respiration, which is called non-phasic sinus arrhythmia. Absence of sinus arrhythmia in children is abnormal. Presence of sinus arrhythmia in adult is abnormal. Right? 3 conditions in adult you must suspect: right coronary disease, sick sinus syndrome, earliest sign of digoxin toxicity are the three important causes of sinus arrhythmia in adults. Right? Then you have a sinus bradycardia, where all the criteria of sinus rhythm is fulfilled, but the rate is less than 60 per minute. Then you have the concept of pause. Pause is a situation or an interval in which there is no QRS. So that is a pause. Once you decide it is a pause, carefully look for the P wave inside the pause. If you don't have the P wave inside the pause, that means sinus node itself is not producing the impulse. It's called sinus pause. It's called sinus pause. Whereas if you have a P wave inside the pause, which is not followed by QRS complex, it is atrioventricular block. Once you decide it's an atrioventricular block, always remember 3 degrees of or the 3 degrees of atrioventricular block: first degree, second degree, and third degree. In first degree atrioventricular block, all P waves are conducted but with delay. So importance of first degree atrioventricular block is always whenever it is associated with what? Bundle branch block or a vesicular block. I told you the approach. If you diagnose a vesicular block, always look for bundle branch block. If you diagnose bundle branch block, always look for vesicular. If you diagnose bundle branch block and vesicular block, you must always look for PR interval. That means you are diagnosing a trivesicular block. There only you have the importance of PR interval. So remember, vesicular block, bundle branch block, associated PR interval. So you have a right bundle branch block, left-handed vesicular block. With a prolonged PR interval, you are dealing with a trivesicular block. In that situation, it is an indication for pacing. Whereas a PR interval prolongation in isolation, without no bundle branch block, no vesicular blocks, you must always look into the drugs. Many times the patient is taking digoxin or amiodarone, verapamil or diltiazem, which may be prolonging the PR interval and so on. So this is the approach to the PR interval prolongation. Some P waves are conducted, some P waves are blocked. You are dealing with the second degree atrioventricular block. Once you decide it's a second degree atrioventricular block, carefully look for the PR interval before the block P wave. If there is a gradual prolongation of PR interval before the block P wave, it is type 1 second degree atrioventricular block, otherwise called Ventiback phenomenon. The block is at the AV node. The P wave is blocking at the AV node. More common in inferior wall infarction, most often conservative line of management. Whereas if the PR interval preceding the block P wave is constant and consecutive, you have a constant and consecutive PR interval, suddenly when P wave is blocked, then it is a type 2 second degree atrioventricular block. The P waves are blocking below the bundle of his. It is a distal conduction block, more dangerous, and most often at this point in time require a pacing because stroke alarm attacks are common. When none of the P waves are getting conducted to the ventricle, then it is a third degree atrioventricular block. Two important points to identify third degree atrioventricular block. First is an atrioventricular dissociation, in which case you have no absolute no relationship between your P wave and QRS. P wave will be falling on different portions of QRS. Some P wave will be sitting in front, some P wave will be sitting just after the QRS, some P wave will be falling on the ST segment, some P wave will be sitting on the T wave, some P wave coming in between T and P wave. So in variable portions of QRS, you will find the P wave. Then it is atrioventricular dissociation. Then see, your atrial rate is faster than the ventricular rate because here the atrium is governed by sinus node, which is faster beating pacemaker, whereas ventricle is governed by a secondary pacemaker of either junction or ventricle, which is slowly beating the secondary pacemaker. So your atrial rate is always faster than the ventricular rate. Once you decide complete heart block, then you decide whether it is a suprahis complete heart block or an infrahis complete heart block by looking at the width of the QRS. If your width of the QRS of the escape rhythm is narrow, that means all your P waves are getting blocked at the AV node and your junction is the one which is producing the escape rhythm. Junctional rhythm travels through the same pathway as the sinus node, resulting in a narrow QRS complex. Then you decide it's a suprahis complete heart block. Stokes alarm attacks are uncommon, usually preceded by a type 1 secondary atrioventricular block. Most often the intervention is the conservative rather than the pacemaker. Whereas if your width of the QRS is wide, that means you infer that your escape rhythm is coming from the ventricle and the subsequent ventricular depolarization is done through the muscle. The impulse is traveling slowly, so it results in a wide QRS escape rhythm. So whenever the ventricular escape rhythm is most often it is very slow, it is quite unstable, and the Stokes-Adam attacks are common. So most often you require a permanent pacemaker insertion for this patient, and the prognosis is poor. So this is what you decide about complete heart block. Once you decide there is an AV dissociation and there is your atrial rate is faster than the ventricular rate, supra is complete heart block versus the infra is complete heart block, looking at the width of the QRS complex of the escape rhythm. So this is the bradyarrhythmia, right? So this is your, you can see the AV dissociation now. So just make sure this is an AV dissociation. The P wave is falling on the T wave just after the QRS. It is coming just in front of the QRS. It is falling in front of the QRS. It is at the end of T wave. Absolutely no relation between the P wave and the QRS. Your atrial rate is faster than your ventricular rate. Then you make a diagnosis of complete heart block. Once you make a diagnosis of complete heart block, look at the width of the QRS. QRS is wide. That means this impulse is coming from the ventricle. That means your block is distal bundle branches or the Purkinje or the vesicles. So it is an infra-his complete heart block. The treatment of choice here will be permanent pacer insertion, right? Then after the T wave, you have a very small wave. Sometimes you see what is known as a U wave. So this is a U wave. I tell you about the U wave. Sometimes after the T wave, you get a very small wave, especially in V2 and V3, which is called U wave. The U wave, they say it's due to the Purkinje fiber repolarization. So just like we told you about the T wave, which is going along with the QRS, U wave go along with the T wave. So the T wave is upright, U wave is upright. The T wave is tall, U wave is tall. So if you have a T wave upright and U wave is inverted, it is abnormal. When you have a small T wave and a big U wave, it is abnormal. So big T wave, big U wave and a small T wave occur in hypokalemia. You have a T wave inversion or the U wave inversion occurring in ischemic heart disease or coronary heart disease. So U wave is inverted, it's coronary heart disease. You will have a low voltage T wave with a prominent U wave, it is hypokalemia. So these are two things you must remember as far as the U wave is concerned. Then of course the entire thing, QT interval. QT interval represents the entire depolarization and repolarization. Normal QT interval should be always corrected to the heart rate. So that's why it is called QTC. So the measured RR interval divided by the root of RR interval gives you the Besset's formula. So this is the corrected QT interval. QT interval can be too long or too short. Long QT interval, congenital prolongation. Or in adult it's drugs. Your amiodarone, tricyclic antidepressants, cisapride, macrolide antibiotics, some antifungals, hypomagnesemia, hypokalemia, lifestyle problems. All these things can prolong QT interval. It's a very dangerous pre-runner of torsade. Torsade, you will have a recurrent syncope. So whenever a syncope in children, whenever a syncope in adult, always make sure you look at the QT interval, right? Syncope and fits in children, always you look at the QT interval. Many times they will be taking years together anticonvulsants without looking at the T wave. So recurrent syncope and fits may be due to Stokes-Adam, due to torsade rather than the interval. When the patient has got a short QT interval, there are only two things. One is hypercalcemia and digoxin. The digoxin is the only drug which can produce a short QT interval. One drug which produces a short QT interval is digoxin. So QT interval can be long, QT interval can be short, and always correct the QT interval with the root of RR interval, which is called Besset's formula. Normal QT interval is around 0.44 second, that is 11 small squares. So 0.44 seconds is normal QT. QT corrected QT interval, 8 to 11 small squares. The normal QT interval is 8 to 11 small squares. So that finishes the entire ECG course in 1 hour. So I want to give you some 10 commandments of reading the ECG now. So always in the ECG reading, you must look at the clinical history and findings. As I started saying that, you must always have a clinical data. The T wave inversion in 20-year-old women may be a different diagnosis versus a T wave inversion in 60-year-old diabetic hypertensive gentleman. So this is a same T wave inversion, but it is the age of the patient And the risk of the disease decides what's the diagnosis you are dealing with. So that's why it's very important. Second, always check the patient's particular. As I told you, make sure the ECG belongs to the patient. Always look at the standardization, speeds, and whether the ECG is recorded properly. Where will you place V3? Between V2 and V4. Said. Have you seen your ECG technician taking ECG? How does he place? Never like that, isn't it? Never between V2 and V4, right? So that's why the ECG recording is more important. Not all ECG abnormalities are disease. You can have so many normal variants. ST elevation, not always acute total occlusion. You can have a early repolarization as a normal variant of ST elevation. Not all T wave inversion are ischemia. You are almost have 15 to 18 causes of T wave inversion. So many conditions. Even a non-specific change. Even normal people, especially women, can have a T wave change, the T wave inversion. So not all changes are diseases. You can have so much of normal variants. You must be aware of what are the normal variants before you attribute a particular change to a disease. In a known patient, always compare with the old ECG. It's a very important rule. For example, patient is a known heart disease patient. Coming to you with a certain problem, you take an ECG. Don't decide on that day that particular ECG. Always ask him to get the old ECG and compare, see to that you are dealing with what type of new change. For example, you are so enthusiastic in your ECG reading, looking at the ST elevation, you would have thrombolized the patient. And the patient brings 7-year-old ECG. 7 years he's been having a persistent ST elevation. You would think it is new, but the fellow would be having a persistent ST elevation due to ventricular aneurysm for the last 7 years. So you are dismayed, you find 7 years back ECG looked the same like the ECG taken today. So you are wrongly thrombolized the patient who does not require anything. So that's why you always compare with the old ECG to decide whether the changes are new. Obvious is obvious, look for inobvious. So ECG reading dictum is you must not look at what others will diagnose. You must always look at what others will miss. So when I see ECG, I see what others will miss and try to diagnose that rather than looking at those things which all others will diagnose. All the fellows will diagnose an inferior myocardial infarction, but I must diagnose a posterior myocardial infarction. I must diagnose a right ventricular myocardial infarction. I must diagnose an atrial myocardial infarction. I must diagnose an associated AV block. So all these things are inobvious. Obvious is inferior infarction. Everybody will diagnose inferior infarction. So the good rule to see ECG is to see the ECG and see what others will likely to miss, and you are going to diagnose what others are missing, will become great in ECG reading. So obvious is obvious. Always look for inobvious. Certain times, especially in children or patient has got a right ventricular myocardial infarction, or the dextrocardia you are suspecting, you must take additional leads on the right side. Or if you want to get the posterior leads, in certain situation, there may be additional lead. Although we say conventionally we have 12 leads, you may need additional lead placements in congenital heart disease, right ventricular myocardial infarction, and also in dextrocardia. Serial ECGs in same position. Serial ECGs are taken not for the income to the hospital. Many times serial ECGs are taken for income to the hospital. Somebody has to see the serial ECGs, and that somebody should know something about the ECG to interpret, and he should always compare with the previous ECG. For that, the ECG should have been taken in the same position. For example, one day nurse comes and takes the ECG in the neck. Other day the next nurse comes and takes the ECG in the abdomen. So you cannot get taken an ECG taken here and the ECG taken here and say the ECG change is irresoluting and so on. So it's a good practice to always mark the first ECG you take in IC, where you are placing your chest leads. So mark those places in which you are taking the first ECG. Daily place the chest lead on that position and take the serial ECGs. Then only there is a point in comparison of the serial ECGs rather than comparing the serial ECGs taken in different positions. So it's a good practice to mark those leads you are taking. Always try to diagnose what the patient has rather than to diagnose what you know or what you read yesterday in the net. So white QRS complex in V1 most often is right bundle branch block. It is not Brugada. Brugada also produces a white QRS complex in V1. But when you have white QRS complex, most commonly it is right bundle branch block. Because you know about Brugada, don't diagnose Brugada. So try to diagnose what the patient has rather than what you know or do what you. So common things are why these things we say for many things, common things are common like this. Many of the ECG changes are not due to cardiac disease themselves. Not all ECG changes are due to cardiac diseases. Your hypokalemia produce changes, hypomagnesemia will produce change, your food will produce a change. So much of non-cardiac influences can completely change the ECG. So I don't think always the ECG changes are always abnormal and always due to cardiac disease. Many times there are so many non-cardiac influences can produce an abnormal ECG. So these are the 10 commandments. If you follow, you will have a very good ECG reading. Each one of you will become experts in ECG reading. So this is, I think many of you would have seen this slide. I always compare the ECG like a swimsuit. It reveals a lot of things, conceals vital things. So sometimes the ECG, although it has got so much of information to offer, it may sometimes conceal vital things. A patient with acute chest pain can have a normal ECG because it may take some time for the patient to have develop the ECG change. So the normal ECG with a patient with acute chest pain does not exclude an acute coronary syndrome. Because you are so much of interest in ECG, you have chest pain, ECG normal, send the patient home, he will not cross the door of the hospital. He will die down at the door of the hospital. So the clinical acumen is important. That's why I told you to become a good electrocardiographer, you must be basically a good clinician. So if you think the patient chest pain is classical of angina, classical of coronary, when the ECG is normal, don't believe the ECG. Believe in yourself, your clinical knowledge, your clinical acumen, and try to admit the patient, take a serial ECG. After 10 minutes or 15 minutes, you will have a classical acute coronary syndrome ECG. Although the present first ECG may be abnormal. So that's why when you know about this, so much advantages are in a particular investigation, you must be always aware what is the limitation of that particular investigation. Then only you will correctly interpret the findings of the ECG. So now the saddest part. So remember these dates. I think you all agreed to come for a high ECG hands-on session on 14/8 in the same hall around 2 p.m. As I told you, we give the ECG book to you, and the workbook is there, and each batch will be having some 5 or 6 people, and our ECG club members will teach you going through the ECGs. So this is the time you tell us what you think in the ECG. You try to interpret the ECG and try to ask the doubts you have in those typical ECGs we have. And of course the examination will be on 16th, the following Tuesday. It's not Thursday, it is a Tuesday. 16/8 is a Tuesday. It's around the same time, same hall. You will have an MCQ examination at the field. And the first 3, and all the people who have attended, and the first 3 will be awarded in our annual day endowment lecture on 16/10/2011. So this is our dates to remember, apart from the ECG. So what we have done today, what I have done for so many classes, I think, some 14 or 15 classes, I think, is to eliminate the fear of ECG. I have not made you the pundits in ECG. At least today, you have a courage to take the ECG and see, at least to read the name of the patient, to look at the standardization, at least to look at the speed. So something you know. So keep taking advantage of this fact and have an interest in ECG and see. Keep seeing, because seeing, try to interpret, get your doubts cleared, reading what you do not know, eliminate your fears and enhance your skills. Continue to have interest in ECG. Ultimately, it is ECG knowledge is not to show off yourself. By diagnosing an axis within 2 seconds, you think the ECG is, ultimately it should translate into patient care. You must diagnose ST elevation MI, correctly give drugs, correctly transport the patient, try to arrange for a thrombolytic therapy before the infarct happens. You must identify the early disease. You must try to identify the early trifascicular blocks and avoid a stroke serum attacks. So much you know, so much you can do with the ECG. So ultimately, this ECG knowledge should be getting converted into good patient care, because ECG course does not end today, right? ECG course, ECG knowledge begins today. Many times the one instrument you must invest as soon as you qualify is the ECG machine. Nobody has lost money in ECG machine. Many has lost money in stock market and so on. But no single doctor has lost money in ECG machine. The ECG machine not gives you remuneration, but it gives you a reputation. Having diagnosed something and you treat the patient and save the patient life, save the patient's myocardium. So it gives you remuneration and reputation. So that's why the first thing you invest after you qualify will be the ECG machine. Exciting journey begins today and happy and enjoyable ECG reading. ECG reading is enjoyable. It's not just a ECG reading, it's very enjoyable. So when you try something, it's very enjoyable. I think for that we must give all our tributes to this man. Who is this man? Who gave you the most cost-effective investigation in the world. ECG is the most cost-effective investigation. 100 rupees, 75 to 100 rupees the patient pays. But see the amount of information and the life-saving treatment the patient is going to get. So that's why we give tribute to this man. So I want to end with defending a cardiologist, right? What do cardiologists do? Of course, others hearts. They stress it, image it, measure it, pace it, shock it, stent it, ablate it, revascularize it, and bathe it in all sorts of drugs. So this is what the cardiologists do. But ultimately, they protect the heart. So I think each one of you to become a cardiologist because it's so exciting field. You can see the benefits of treatment immediately. So because as you know, our India is at the verge of having already facing the epidemics of coronary heart disease. So we have a huge incidence of coronary heart disease which is coming, cardiac disease which is coming. So I think all of you have interest in cardiology, ECG, and each one of you become a very great cardiologist. Not only an invasive cardiologist, but also a preventive cardiologist, a cardiologist who has got faith in prevention of diseases rather than treatment of disease. So my thanks to my Pfizer, as you know, the Vaidyanathan, so the Pfizer Vaidyanathan and Simpla Balraj, who have been our helpers here, who have done a great job. Our Secretary Balasubramaniam, and of course we are recording this all these lectures and audio visual Rajgopal and this for this wonderful hall for this hotel. So this is the ECG and Echo Club of Trichy, and we have a website here. So I direct you to visit this website. Every 15 days we post an ECG here. So try to interpret this ECG. You will have once again 4 multiple choice questions. The answers will tell you whether you are right or wrong. If you are wrong, this will tell you why you are wrong and ask you to select the right answer and try to select the right answers. And we also give a practical tips on every 15 days regarding certain drugs, how to treat and how to use a particular cardiac drugs and so on. With this, I thank you for your consistent interest and coming all the way consistently for so many weeks. Thank you for your patience.